I'm Julie Cameron. I'm the Associate Director with the Mental Health Foundation, so I oversee our work in Scotland. And today I'm going to just be taking you through a presentation, quite an introductory presentation around tackling the inequalities that drive mental ill health and poor wellbeing. And this will be based on some research that we've done and wider learning from others. So just for those of you who might not know who we are, so Mental Health Foundation, we're a public mental health charity, so we don't deliver services as such. We have a mission that we believe that no one living in the UK should be deprived of good mental health because of who they are, the community they come from, or where they live. We are a UK-wide organisation, so we have a presence in Scotland, England, Wales and Northern Ireland. How we do things, how we take things forward is we do some policy influencing work, we do research, we do primary research. We also do test of change programmatic work, but we don't, as a rule, deliver services. And we also do campaigns. So we're the home of Mental Health Awareness Week. So that's just a little bit of who we are. And I won't go into this, but that just gives you a sense of what our strategic focus is and the specific priority groups that we aim to work with. And it's probably worth saying that the work around poverty and wider social determinants cuts across all of our work. So let's just start at the beginning in many ways, really just exploring what do we mean by health inequalities. And effectively what we mean by that is we mean the difference in health outcomes depending on which group you're in, whichever that may be. And in our society and in many societies, particularly within the Western world, we have a situation where we know that a number of factors will influence your health and your mental health. And what tends to be the case is that if you're born into circumstances where you have already more protective factors, you're more likely to have good health, better access to health services. Therefore, it's quite a self-fulfilling cycle in terms of your health outcomes. And conversely to that, if you are born into circumstances where you have already more risk factors to your health or your mental health, then you're more likely to have poorer mental health outcomes as you grow and develop into an adult and poorer access to the healthcare system. So that's just some of what we mean by health inequalities. And effectively what that means is that from the outset, the odds are stacked in favour of the better off. That tends to be the way it is. And what's quite important to reflect on is that health inequalities many of them are often avoidable, but unfair and systemic differences in health outcomes between different groups of people. And Sir Michael Marmot described that as a matter of social justice. So because these are factors that can be influenced and can be changed, it means that it is this matter of social justice. And I think this is really important, second half of this quote, where he then goes on to say, but the evidence matters, good intentions are not enough. And I think we would all identify and recognise that over the years, there has been quite a lot of money sometimes placed into good intentions rather than evidence-informed approaches. And actually, that's not the way that we want to go. We want to be able to ensure that we're investing where the evidence suggests greatest impact will be made in terms of reducing those health inequalities. So coming on from that, let's bring this into the mental health picture. So as you know, we all have mental health. And of course, at an individual level, we can all experience mental health problems, whatever our background or the walk of life that we come from. But we know that the risks for mental ill health are not equally distributed. And that these inequities that exist between mental health outcomes are driven by the circumstances into which we are born, live and are raised. And those circumstances, that collective that covers so many different facets and factors, are effectively social determinants. So that's what we mean when we use the language of social determinants of health. We mean all of these influences that go beyond our genes and our biology, how they influence our health outcomes, or in this instance, our mental health outcomes. So that's what we mean. And I'm just going to go through a little bit what I mean across each of these and what these might look like in practice. And then Ailey and Lindsay will kind of bring to life some of these specifics in their presentation, so that they'll be a good follow-on from me. Okay, so we'll just work through this. So we did a piece of work with the London School of Economics not very long ago, within the last few years, where we asked them to do an economic analysis really of what the mental health problems cost the UK economy. And this is what they came up with, nearly 118 billion, a significant figure. And I have to say, by their own admission, this is probably quite a significant underestimate, because in that economic analysis, they really only included some quite hard factors that they were able to put kind of solid economic numbers around. And in Scotland, that's about 8.8 billion. So we know that there is a real financial drive to do better around mental health outcomes. It makes financial sense. One of the biggest influences on mental health is undoubtedly poverty. We know that there's about 1 million people in Scotland who are living in poverty. Up to a quarter of children are living in poverty. And we know that if you happen to live in those areas of poverty, you are 2 times more likely to experience anxiety or depression, that you're 3 times more likely to die from suicide. So at a population level, there is a real imbalance between those who live in more deprived communities and those who live in more affluent communities. And we know that if you're a child who is born into a low-income household, you're about 4 times more likely to experience mental health problems as you grow into an adult. So these are stark and very real for the lives of people. And of course, there's multiple reasons sitting behind that. We also know that it's not just about the area that you live and whether you live in poverty, but also whether you're in employment. So being in employment is a real protective factor, and conversely, being unemployed is a real risk factor for your experience of mental ill health and mental distress more broadly. So you can see some of the comparative stats there. Around 34% of people who are unemployed will experience mental distress, compared to 16% of those in employment. And we know that job loss has a very traumatic and immediate negative impact on mental health, and that damage can be compounded when that unemployment is long term. We also know that low literacy and school dropout are both associated with greater risks of mental health problems, and that is particularly problematic in today's climate, where so many of our young people are saying that they feel that getting a job feels really impossible. Oh, hold on. Just trying to get this to share. So actually, before I go into that, one of the other things that's quite useful just to point out here is that some of the research that we've also done, it tells us not only is it about being in employment, but having a stable income has a significant impact on your mental health. So those that have an unstable income, that has a real high level of risk associated with it in terms of your mental health. So not knowing what money you're bringing into your household on a month-to-month basis or on a week-to-week basis. And that obviously has quite significant implications around 0-hour contracts and other kind of more insecure types of employment. So what about different relational influences? So one of the things that we know is that being identified within a particular cultural or social group can bring with it higher risk of mental health problems. And it's important to point out at this point, that's not because of genes or a kind of biomedical marker that you have within your own self, but largely because as a society, some groups attached to particular identity groups or particular cultures are much more likely to experience adversity. And that includes some of the specific groups there, and will include things like experiences of discrimination, racism, bullying based on sexual orientation, gender identity, sexism, all of these factors. So it's not about you being part of that identity group in and of itself, it's about the wider life experience that come as a result of that. And many of you will know now the spotlight that's been placed on adverse childhood experiences in the last kind of 10 to 20 years. And that's because we know that adversity in childhood has such a significant impact on adult mental health problems, whether you will develop a mental health problem as you move into adulthood. But of course, we also know that adversity in adulthood, trauma, is in and of itself also a risk factor for increased mental health problems. So this is a really, when we're talking about that relational influence, it's really about your exposure to adversity. And one of the things, just to bring this to light, that I won't dwell on this too long, but this these slides, what they show, these are from our study that we did, which was called Thriving Learners. So this was one of the largest student surveys that's ever been done actually in Scotland. It had about 15,000 responses. This is just about 2 years ago when we released the findings of this. So we had over 15,000 respondents, which is about 6% of the student population within HE. And the reason that I was showing you this is I just wanted to demonstrate to you just how increased your likelihood is of experiencing, in this instance, severe symptoms of depression or of concealing a mental health problem as now due to perceived stigma with those who might fall into a particular identity group as compared to the wider student population, as was this study. So really quite significant differences there, as you can see, in terms of that. Under other genders, 36% have experienced severe symptoms compared to 16% of the all student population. So let's think about how health, disability and ageing influences your mental health. So again, you may have seen at the start there when I was showing you the Mental Health Foundation's priority groups that people with long-term health conditions are one of our priority groups. And one of the reasons for that is just because of how that increases your risk of developing mental health problems, specifically anxiety problems or mood disorders being particularly common. And we know that people with, again, physical, sensory or intellectual disabilities are at higher risk of having a mental health problem. And again, that likely ties back into, for some people, back into that experience of adversity and discrimination and stigma, and how all that interplays in terms of the actual physical, and also, of course, for people with long-term health conditions, also just living with pain and living with limitations can have an impact on your mental health. We also know that gender and age has an impact on your mental health. And where this starts to become really important to consider is not in and of itself, but actually the response that this then requires from a service perspective. So if we know that 1 in every 10 women are affected by postnatal depression within a year of giving birth, it's then upon us to make sure that actually there's resources there to be able to identify women in that first year who may benefit from supports, and make sure that the investment is placed in that. And that's the case across all of this. All of this information is not just for its own sake, it's to help shape what should be the response then in terms of where we place supports for mental health. And you may be familiar that the Scottish Health Survey continues to show gender differences between men and women. And for the vast majority of that is women who are faring worse. The exception to that, of course, is suicide rates, where it's middle-aged men who are much more likely to have higher risk around that. We also know that there is a real risk factor for ageing, particularly retirement, where increasing numbers are not only living in persistent poverty, but also that's where factors like increased levels of isolation and loneliness start to come in, and that can have a real detrimental impact on your mental health. And again, thinking through the environmental influences that influence your mental health, and of course safe and secure housing and those making sure that your immediate needs are met is one of the most important protective factors, if you like, for your mental health. And we know that many people are not able to be in safe and secure housing or not having their immediate needs met. And again, that graph on the right hand side just demonstrates some findings from our Thriving Learner study again, which just demonstrates experiences of insecure food insecurity and how particular groups, this links very much with previous slides around the relational, that you can start to see how all of these factors interconnect, that if you're in and if you have a particular life experience, you're more likely to be to have experiences of food insecurity, which again is likely to have an increased risk for your mental health. So all of these factors interconnect. And of course, we know that the impact of the pandemic was to really exacerbate some of these existing inequalities that were there pre-pandemic, but have really worsened since post-pandemic. Okay, so that's some of the influences on mental health. And as I say, that's a kind of collective overview of some of the wider social determinants. And I guess importantly, it then gets to the point of, well, what can we do? What are the interventions, approaches that we can actually do to start to tackle this? And really a public mental health approach is when you take interventions that will help to improve the mental health and well-being of the whole population, but whilst reducing the inequities within it. So not taking your eye off the need to reduce inequalities. And actually that's not always been the case for some of our public health interventions. Some of our public health interventions, particularly those around parenting and other areas, we know inadvertently in some instances have actually widened the inequalities, and that for a whole host of factors. It can be because actually what tends to happen if you have a Get Active initiative or whatever it may be, is that actually it's the kind of worried well. So those who may have slightly more protective factors already in their life, but it would be those who would step forward. Now, of course, they absolutely have a right to engage with interventions that will improve their health and improve their mental health. But it's really important that we consider what the ongoing barriers will be for those in our communities who are already at higher risk because they have most disadvantage in their life. So we really need to think about that when we're developing services and we're developing interventions. So taking a public mental health approach, it's really important, but as I say, it's got those two aspects to it. So yes, impacting the outcomes of the whole population, but making sure that actually we're working to reduce inequalities and not inadvertently increase them. And really, as you know, taking a public mental health approach encourages you to take that whole system lens across all the different factors that will influence people's mental health. So thinking about biology, but absolutely thinking about those social determinants as well, and thinking about how we can ensure that our services really meet the needs of those who have had those experiences of trauma, adversity, and systemic oppression. So very quickly, I'm just going to run through. So that piece of research that I referenced at the start that we did with LSE, as well as doing a kind of economic analysis around the cost of mental health problems, we also asked them to give us an insight into actually where does the evidence tell us that we should be investing to be able to make a difference and to tackle the inequalities that exist around mental health. And it should be said again that invariably when you do a review of this type, the types of interventions that come out tend to be where there's most evidence, and there tends to be most evidence, particularly evidence that's published within journals, within that kind of clinical therapeutic sphere, as opposed to very much that kind of social intervention space. So that's probably reflected in the types of interventions that are suggested here. But one of the first things that came out was that there is increasing evidence around if you have increased investment for interventions that take a public mental health approach and or will help to remove people from poverty, that will have a significant impact on people's mental health. And we know that the mental health strategy and any mental health strategy, not just the government's, should take a cross-departmental approach. And that's to recognise actually, as we've just touched on in terms of looking at the social determinants, the opportunity for mental health services to influence in these spaces is actually quite limited. Actually, the opportunity for health to intervene across a number of these interventions, across a number of these areas, is quite limited. We need this cross-departmental approach now if we want to really start to work much further upstream in terms of a preventative approach. So thinking about how we can make changes within education, within housing, all of this, of course, falls out the realm of health or mental health. So some of the interventions that come out strong in terms of evidence at an individual level, mental health training for health visitors. You can see how that absolutely talks to that risk factor that I was talking about in terms of gender and becoming a mother. So that perinatal space. Parenting programs, we know that evidence-based parenting programs for the whole population, but there's also some good evidence for those that are really targeted at those where that parenting support's most needed. We know that there's a good evidence base for anti-bullying programs in schools as a preventative measure for poor mental health. So bear in mind, these are all about preventative measures for poor mental health. Of course, they will have other benefits, but this was just with that eye to it. And exercise opportunities. And particularly being able to establish interventions that intervene early for people who have got a kind of risk of poor mental health in terms of providing them with psychosocial or psychological support. We also know kind of further individual change interventions that have come through as being evidence informed are workplace interventions. So we are a managing partner with CME, and they've been doing some fantastic work in this space. And we also this idea of brief interventions for long-term health conditions. So quite often that's looked the other way when people have long-term mental ill health. We know that their physical health can deteriorate, but actually it goes the other way too. People who live with physical health conditions are a much higher risk of their mental health deteriorating, and actually having brief interventions in place can be really beneficial as an intervention and as an investment. We know that there's good evidence around putting money into interventions that support social opportunities for older people, and of course suicide prevention measures. And in particularly within that suicide prevention measures, where the evidence suggests is around restricting access to means, but also really early identification if people are presenting in hospital or in primary care as a result of self-harm, and putting in interventions that would prevent further self-harm as a measure. And then at an organisational level, there is increasingly good evidence that taking capacity building models, and what we mean by this is building the capacity to be able to better discuss and respond to mental health distress among non-mental health specialists. And certainly that's something that we've been doing quite significant amounts of. And task sharing is a very particular model around that, which it was developed in low to middle income countries, and then it was adopted more fully by an initiative called Thrive New York City, which was one of the biggest public mental health initiatives that's ever been invested in. And effectively, it's about taking tasks that perhaps would have seen at one point as the domain of quite highly specialised staff, and exploring which of these tasks actually are better placed and can we train and support staff who work within the communities to deliver. And that is effectively what a task sharing model is. So it's about trying to really tackle that treatment gap, if you like, particularly in areas of low income or high need. So they are just a very quick fly through, and I know, as I say, that Ailey and Lindsay are going to give you an opportunity to kind of bring some of that to life in terms of some of these interventions in action. But that was just where some of the evidence lies, as I say, from that LSE report that we commissioned. And I guess, what does success look like? Well, for us, that would mean a fundamental shift in key health and social policies to enable this mental health in all policies approach, so that we can really start to spearhead preventative action that has the specific goal of improving mental health and building the protective factors around a person's mental health. We know that we need more community-based preventative mental health supports, and we also need to continue to build the evidence around that. That's an area that's largely untapped in terms of the evidence. We know that there's much more evidence in clinical settings. We need to start to build that evidence in more community-based settings, because we know that it's really a great opportunity to build on the trust that individuals already have within their communities. And we would like to see millions more people empowered to manage and support their own mental health. And obviously initiatives like Mental Health Awareness Week can help support starting some of that conversation.
So what I'm going to be giving is a kind of overview of the picture within Ayrshire and Arran, looking at our 3 partnership areas: NHS Ayrshire and Arran's a health board which works to 3 health and social care partnerships in 3 local authorities, being East, North and South Ayrshire. So I'm going to give an overview of some of the differences between them in terms of things like poverty, and also how we can see that playing out in terms of some of the mental health outcomes and evidence that we have. So while this is an Ayrshire and Arran kind of focused presentation, I've not got the links in the slides, but I can share the references and the links to where the data came from, as you'll be able to go on and find the same information from national websites, databases, etc. for your own area. So just get started. So these jigsaw pieces here are really just giving a kind of overview in general of the population in terms of where we might see people and where we will find them and what type of service and support they need. So generally there's roughly 80% of people who are getting by. That's people who are doing well. They'll just have universal services, primary prevention, as Julie mentioned, being key, thinking about relationships and 15% we're looking at that getting help, and this is where that prevention moves to early intervention to stop things getting worse, and that's sometimes classed as secondary prevention, and that's looking at maybe responding to issues around substance use, family and risk factors, and that timely access to a trauma-informed response. For that 4% of the population, they're looking at maybe needing some more help thinking about our tertiary sector and tertiary support, and that's about timely access, crisis support, and detox rehab. And then we'll have that small 1% who will present and come to us through emergency and out of hours presentation for that immediate informed response, and then present through police custody and emergency department. So I'll talk about relationship inequality briefly and then come on to the wider circumstances and that kind of structural inequality as well. So we are all each shaped by our experiences in relationships, and especially those relationships with our parents, and they in turn have been shaped by theirs. And it's during these early years that we develop these skills and competencies to navigate and negotiate the day-to-day life and all the challenges that day-to-day life brings with it. So these skills and abilities that we develop are greatly facilitated when the human needs and wants of that secure income, sufficient income, warm, dry housing, and access to good quality food is available and affordable. And I'll come on to talk about that a little bit more. And thinking, moving on from the relationship inequality to structural inequality, this is where we're thinking about that insecurity and uncertainty regarding income, housing, and food, and how that then impacts on people's abilities to, for example, display healthy behaviours, be part of society, and look after the health of their families. So these wider circumstances of a family life are generally shaped by the physical and material resources that they've got access to. And within Ayrshire and Arran, 1 in 5 children in North Ayrshire and 1 in 3 children in East Ayrshire are growing up in the 20% of Scotland's most deprived communities. So these are the areas where insecurity of income, food and housing creates challenges in family life, and it will also impact adult well-being, parental well-being and relationships, and it can leave less time within families and communities to attend to the needs of children and young people during the key developmental phases, which then will play out across the life course. And within Ayrshire and Arran, we are taking a life course approach to public mental health, as Julie's already defined for you, and looking at mental health as a resource for life. So understanding as a resource for life brings about these opportunities for parents, families, communities and systems to come together, bringing that broader understanding to the nature and origins of our mental health, and mental health, that should say mental health need, not mental health need, for individuals, families, communities, and really thinking about the importance of those early relationships and experiences and not underestimating them in terms of how that will play out across the life course. So just talking about the life course, I will not go into this in great detail, but the slides will be shared. So we take a life course approach to mental health in our public health department in Ayrshire and Arran, and that is a life course approach to identifying that good growth and development as it influences health and well-being is going to reflect the joins across both our individual and collective lives in the context of that wider system that we live in, work in, play in terms of community, environment, and those political and economic systems as well, where policies are made that actually impact the daily lives of the people within your communities and the people that you work with and support daily. So Julie's already went into the 4 main categories of the factors that play out across the life course, namely the economic influences, the other relational influences around around sexual orientation, the disability, health and ageing, and environmental, thinking about safety, housing, and access to green and blue space and transport links. So these really early stages of the life course really influence what plays out, and it's the different responses that we have at each of these stages and across them to try and support people with these wider social determinants in order to improve their mental health and reduce mental illness. So this slide here is showing this local picture, and we spoke about children in poverty. So this is children who are living in relative low income families. So you'll see there our East and North Ayrshire areas. I've got the highest child poverty rates within Ayrshire and Arran, and South Ayrshire, which is our generally classed as our more affluent locality, has now overtaken the Scottish average in terms of child poverty rates. And while these rates kind of sit around that 25% up to 30% for East and North, that's not to say that that is the maximum, that's the average. And even within South Ayrshire, we've got really deep pockets of deprivation of 40% of children living in child poverty in some areas. So we can see that there's been quite a kind of we've not been doing well, I'm afraid, in terms of getting these figures down. There was a dip during 2020-21 when COVID was happening. Part of the reason for this dip is because the data wasn't available in terms of being able to make a comparison to other years, but also there was a lot more protective factors put in, be it furlough and increase the Scottish child payment. And unfortunately, we saw that steep increase, and that's stubbornly persistent at the high rates across Scotland. And we do obviously have the national targets, which we are quite far away from in terms of delivering on the reduction of child poverty. However, the Scottish Government has committed in its programme for government that's just come out that tackling child poverty and eradicating that is a #1 priority. So this similarly shows the percentage of young people living in the most income-deprived areas within Ayrshire and Arran. And again, you'll be able to access this data for your own areas, showing that in North and East, young people are living in much more deprived areas compared to a higher number compared to Scotland, and South, which is just below it. And these factors are key to developing and sustaining resilience. If people are growing up in deprivation, this then influences across the life course. And there's a clear disparity even between North and South, with about 3 times more young people in South Ayrshire living in the most income deprived parts of Scotland compared to South. So very quickly, because I'm aware of time, we in Public Health in Ayrshire and Arran looked at an English survey which was carried out to identify the projected kind of mental health need of children and young people, and we applied that to our population figures within Ayrshire and Arran. And from that, we were able to see these figures rising. And again, you'll be able to see that that plays out across East, North and South based on those areas of deprivation and the ones that are experiencing the most deprivation. It's also shown that that is likely where that more intensive need for mental health support will be across the different age ranges. And we did hear about, the population and prescriptions. So this is looking at Ayrshire and Arran and the percentage of the population who are actually being prescribed medication for anxiety, depression or psychosis. And that dark blue bar in the left-hand side is for those living in the most deprived of our communities, over to the light blue at the right for the least deprived. So we've got an average of just under 23% of people in Ayrshire and Arran being prescribed medication for mental health issues. And I do truly believe when we look at what the slides I've just shown and Julie's presentation, and we know that these are the issues that are affecting people's mental health and ability to navigate life, and it also affects suicide risk, etc. What else is happening, and as well as this medication, while it has a place, it is not appropriate for everyone, and we really need to be looking at that wider political, environmental and social environment that is influencing and affecting people's mental health on a daily basis. And again, this is just shown across Scotland. This isn't an Ayrshire and Arran specific picture. This is looking at Scotland from the most deprived in the left to the least deprived in terms of the prescribed medication. And on the right hand side, this is the kind of trend shown over time, and we're seeing increases across all of the 5 quintiles of deprivation, with the most deprived being that black bar right at the top there. So that is quite bleak thinking about these communities and thinking about how it plays out from the start of the life course. These young people aged just 27 to 30 months, this is the age group. This is where there's developmental concerns at the 27 to 30 month review, and right at that early stage of life, they're already being impacted across those areas of deprivation when we look at the differences there between the least and the most deprived. And those factors will play out across the life course, and I think we can all agree it is a stark inequality and unfair that children should be having different experiences and developments based on where they're living. So just to finish up before I hand over to Ailey, within North Ayrshire, they set up a Tackling Child Poverty Board a few years ago, and they then spoke to government to incorporate that to become a Tackling Child Poverty and Cost of Living Board. So that board now has carried out lots of mini inquiries with organisations, third sector and people with lived experience and the people in communities. They've expanded, as I say, to incorporate the cost of living, and they've developed a 3-year strategy and established a cost of living fund, and they've also received funding through the Child Poverty Accelerator Fund to implement a no wrong door approach, where people will receive a single shared assessment to try and get people the money that they are due and that they are entitled to without them having to visit lots of different services. And as Julie mentioned, Mental Health Week, just to say I can also send some information out because Suicide Prevention Day is coming up in the 10th of September. So it would be great to get some information and messaging over as this year's, the theme of this year's Suicide Prevention Day is changing the narrative and getting us all talking about suicide and suicide prevention.
Yes, so my work cuts across health and social care, communities, primary health care, and also work very closely with Lindsay at Public Health and alongside CAMHS. The examples I'm going to show you, and I'll probably skip through them because I'm very aware that we're running out of time, will have a children, young people and families focus because that's the area of work that I'm involved with. But it's really bringing to life some of these influences that Julie spoke about and how we've used this grant funding to address some of the social determinants of poor mental health and well-being. Okay, so first of all, the economic influences of poverty and income. We used some of our funding to start a welfare rights officer in schools project. It's been in all of our secondary schools. We've got 9 secondary schools in the local authority, and we've had one worker working across these 9 secondary schools. She's done a phenomenal amount of work since the project began just slightly over 2 years ago. The financial gains for our families have been over £1 million, with the previous financial year ending end of March 2024, there was 560,509, and that's money that came into people's pockets. There's a case study there where a referral came from an area inclusion worker within the schools. There was a benefit check and an income maximisation done for the client. She was a lone parent. She was really struggling to meet the needs of her children. And the outcome of that was that she had a monthly better off income. Her income was increased each month by £1,245 per month. And then she received money in arrears. Now, the links, there's so much evidence around the links between poverty and mental well-being, that having money in your pocket is going to address some of these barriers. I spoke with our elected members prior to the budget setting for this coming year, and they agreed within the council budget to fund an additional 2 welfare rights officers for a period of 2 years. I'm very excited about this. They're in place. They are covering all of our secondaries, our primaries and our early years centres across all of the localities. And I'm really looking forward to hearing about the impact that that's going to have on some of our children and families. In terms of employment and education, the Welfare Rights Officer in Schools project doesn't only complete financial insecurity and income maximisation assessments with our families, but they also provide guidance and support to education staff so that they're in a better position to support families, and also to the young people as they transition to life beyond school. We also, within the local authority, have BU ambassadors, and they are really, it's capacity building in action. They're modern apprentices. They go into our primary schools. They deliver a programme we call Your Resilience, and the young people involved, who are primary 6 aged pupils, all become mini mental health ambassadors in their schools, and it helps them to develop their emotional literacy and to work with younger children in the school in terms of friendship and buddying. I've got a few pictures of that later on. They collaborate, our mental health and wellbeing project delivery officers collaborate with staff at Ayrshire College to support staff to build resilience in young people in deprived areas. And in addition, they're also collaborating with Mental Health UK to develop a Me and My Money pilot. That's got 3 main objectives. It's really about supporting young people to look at their relationship with money. It's about providing them with an understanding of the interconnection between money and mental health. It's about empowering them to understand how our attitudes towards money influence our thoughts and behaviours, and equipping them with a suite of skills and tools related to money, which they can use to support themselves as they move into the future. Alongside that, the work that I do, we are in the early stages of strengthening our links with Skills Development Scotland, and that's really to try and support young people who are at risk of becoming economically inactive when they leave school, and also working with the young economically inactive to support them into employment or education. Again, some of the impacts the young people at the college reflected on the programme. One of them had said that it gave them an opportunity to learn how to handle difficult situations and how to solve issues. And in terms of the mini ambassadors within the schools, they had made up these wee friendship recipes, and one wee one said, you all helped me realise not to care so much about what others think. I've learned to believe in myself and try to stop doubting myself if I fail. So this development of this emotional literacy should help towards reduce some of the impacts of mental health stigma and discrimination, which Julie spoke about in her presentation. Looking at the relational influences, we're obviously very involved with equalities within North Ayrshire, and particularly with our young people. And as part of the North Ayrshire's youth participation strategy, we have developed an equalities programme, and 3 of the main areas of focus are the LGBTIQ+ young people, children with additional learning support needs in schools, and our young carers who have multiple barriers in their lives that can impact on their health and well-being. One of the successful projects that we did was that we took a group of 20 young people over to Arran to take part in Arran Pride, and they had a great time over there, mixing with young people from all over the local authority, and becoming engaged with the community on Arran. And there's just a quote, and as I say, I'm very aware of time, but there's a quote there from a young person about what they'd felt being involved with that group. The Equalities Programme has also been working on kindness murals, and you'll see a picture there. These are just messages that are around the local authority. They've been developed with young people, and it's hope. That's the real focus of it. Hope, keeping well, and embedded within each of the kindness murals is a QR code, and young people can scan the link, and it helps them to find out about well-being supports and activities and services that are in their local area that they could become involved with, whether they're around specific supports if you feel that your mental well-being's poor, or it's maybe about exercise or things that can address social isolation. In terms of relational influences, transition and childhood trauma, we know that that has a huge impact. And one of the things that I procured as part of the Children and Young People's Communities Mental Health Supports and Services was to pay for a play therapist to be based within our fostering, kinship and adoption team. She's had a huge amount of impact on the young people. Over the period of the last 3 years, approximately 120 children have benefited from this service, and she also was able to support families. The Health and Social Care Partnership have looked at the evaluations of this work and have now made that a full-time permanent position within the team and are paying for that work themselves. And the two quotes that I've highlighted really say it all. This is a carer of a child accessing play therapy. She said he was never invited to birthday parties by children in his class, but this has now changed. He was so excited to go and he had a great time. Now, for me, that speaks absolute volumes. The young person is benefiting from the time they've been spending with the play therapist, engaging in that therapeutic intervention to address the childhood trauma. But the other children have noticed, and the parents of other children have noticed the impact that it's had. And then a wee tootie, just a wee 5-year-old, had some time with the play therapist, and when asked how she felt things were going, she said, "Now you've made my heart full of sunshine." And I think if that doesn't cheer you up on a Thursday afternoon, I don't know what will, because it's just an incredible thing for a wee one to say. We also have dance therapy ongoing, where around 300 people have benefited, 300 children have benefited from taking part in that. And again, that's work that's done alongside their families, bringing them together in an environment where they might find it easier to talk about things. Now, I'm going to skip through these next few slides, but we know that family wellbeing is at the core of supporting children and young people with their mental health and wellbeing. We co-produced a family-centred wellbeing support service around the principles of getting it right for every child. We have listed the reasons that young people would be referred to the family-centred wellbeing support service: distressed behaviours, poor attendance, families where they're just absolutely stuck. There might be a breakdown within family relationships, struggling with routines and structures and boundaries, cost of living crisis, housing issues. So it's a kind of almost one-stop shop early intervention for families who might otherwise end up having to come into social services under compulsory measures. The team provide a number of evidence-based interventions, and there are principles like signs of safety and Safe and Together that they work around. I won't go into all of that. I think what's really important that you hear about is the impact. So education staff are able to make referrals, and service access, who are our kind of gateway to all social services, they can make referrals to the family-centred wellbeing support service. These figures are for the end of April, where over 200 families had been supported. In terms of the makeup of the children, 70% were boys, 30% girls, and you can see the balance of where the referrals had come from. And just, the team, they know the team well due to previous delivery. These were SNAP workers. It's an additional resource. It means that they can come in earlier before there's any need for anything like child protection. And then what the families say, that they took time to really listen and understand what we were going through. It took time to start feeling like we had confidence and skills to manage the behaviours, but they got there, and it was through the patience and understanding. The helpfulness of the team. They've all been trained in sleep awareness and sleep hygiene, so they were able to help families where there's been long-term sleep problems, and then the impact of having your sleep dealt with then on your confidence and your mental well-being. So I'm sorry this is so rushed, but I want you to have an opportunity to ask some questions. Another of the relational influences that we have really looked at is social isolation. We worked with our communities and tried to identify the gaps. We discovered that young parents were sometimes really struggling. So we set up a young parents group in the Three Towns area of North Ayrshire, which is really one of our lower socio-economic areas. There's a new one just started in Irvine, and it will spread right across the local authority. But it's really about promoting socialisation and interaction, helping to develop parents and babies' social skills. The young parents had said that sometimes they felt intimidated going to mother and toddler groups because the mothers were all a bit older and maybe looking down on them. So it's working with them to build their confidence to be able to join in some of these social activities. We also have what we call Take Time Families. It's a group that works, we run it out of a library so that it's in the local community, and it helps families to establish a good understanding of mental health and well-being. It's for parents and carers of primary age children. The referrals come either from the school or from community link workers or from youth workers. And they have activities for the children separate from the parents. There's a bit of discussion goes on with the parents, and then they bring them together to carry out some activities that link into areas that support healthy mental health and well-being for both. So it's just about that early intervention, helping the caregiver and the child to become more resilient. And that dad there talks about how it's not just himself that's been impacted by it, but his daughters and how she reacts positively. Julie also spoke about the environmental influences, and the group teamed up with the Eglinton Park Ranger Service and the Climate Change Ambassadors to help promote a healthy planet as well as a healthy mind. It's really a very important collaboration for us. So they planted an orchard together, and then they put a time capsule in with some positive messages to be opened in 2033 as part of that Kindness Murals youth project that I spoke about. Other interventions that we have invested in, one called Mind and Be Active, where young people who, particularly as an impact of the pandemic, had perhaps been struggling to get into employment or education, ones that had left school during the pandemic, and the KA Leisure, who are one of our leisure company attached to the local authority, do work where they take them out for walks, help to build their confidence, get them into the gym, get them doing some physical activity, and that then has that impact on their mental well-being, and then help to support them into either education or employment. We work with families on a program called Building on Positive Relationships, which is really about families who are completely stuck. We do lots of suicide prevention training for education staff. We've commissioned Penumbra to deliver a self-harm support for children aged 10 and over. And I'm almost at the end here to give you an opportunity to ask questions, but I just wondered, we're in such a difficult economic time at the moment, all those of us who are working in local authorities and leading local authorities. I just thought it might interest you what the cost of some of these projects that were put in place are. I thought Julie's quote right at the beginning was saying that evidence matters, good intentions are not enough. So I've got screeds of evidence about the impact of these projects that have been put in place. So the 2 mental health and wellbeing project delivery officers, they cost £84,000 per year. They're engaging with over 5,000 young people over the space of a year, whether it be signposting or the young parents group, the Take Time Families, the work that they do in schools with the mini ambassadors, the peer support programme they run, and the impact of that is irrefutable. The cost of the 3 welfare rights officers in the schools is £125,000, and a play therapist costs around £60,000. And all of the work I do does link in with other policy areas which I have listed there, in particular the Promise, the work around the Whole Family Wellbeing Fund, and the Child Poverty Action Plan. So that's me